Perfect. It is Good News Thursday, and I have some good news. So, first off, Dusty has been doing full fitness recently. It's been on Dusty, and she said that last Friday she herself, and she did it to a sold out crowd at the Blue Note. So that's amazing. Then, secondly, Sir has been scheduled, and we're going to be meeting with Dr. Hardin. Dr. Hardin is our former chair, and so I think he'll bring a nice perspective on negotiations from both sides of the table. And I think it'll be really beneficial for us to look forward to. Even though Dr. Canali isn't here, the GSA, and I'm sure all of you want to just extend our good wishes to her. She just got this transition director interviewing process. It is not easy, so all the best. And then lastly, just two reminders: the ACSM Travel Board application is due tomorrow, so please submit that. And the t-shirt sale is still ongoing, so spread the word. And that's it.
It's my pleasure to She completed an NIH-funded postdoctoral research fellowship in the Division of Endocrinology, Metabolism, and Diabetes in the Department of Medicine at the University of Colorado. And she received her PhD in clinical physiology and metabolism from Virginia Tech in 2016. She's also a registered dietitian. Her research focuses on appetite and food intake regulation in response to lifestyle interventions such as dietary restriction and exercise. And she has numerous projects going on. Some of her current projects are examining the impact of resistance exercise timing on glycemic control and sleep in older adults at risk for type 2 diabetes, targeting weight regain, using circadian-based time-restricted eating interventions to lower risk of diabetes in people with short sleep duration. So very interdisciplinary research over here. Another one of her projects is examining the effects of whey protein supplementation during the competitive season on athletic performance, recovery, and body composition in high school soccer players. So her research is funded by the KL2 Career Development Award, Western Dairy Center at Utah State University, the Margolis Foundation, and the University of Utah College of Health at the University of Utah, and that's quite an accomplishment. She also does extensive scientific outreach via Twitter, so I don't know how many of you follow her, but please do. It's always a treat. So with that, please welcome Dr. Halliday.
Thank you. Okay, so I'm going to try to use this, but also stay close to the computer. So with everyone here and see your awesome facilities. So I'm here today to talk about a topic that I'm sure everyone is familiar with, and that's weight management. So you don't have to do a show of hands, but maybe just think to yourself, how many of you have tried to lose weight before? Or maybe had a friend who dieted and lost a lot of weight before their wedding, only to be really disappointed when they regained it afterwards. Or perhaps you've been a caretaker for a family member who's dealing with some of the comorbidities from, an obesity-related disease. And so I think all of us, know how challenging losing weight and keeping it off can be. And my research is really focused around how can we do this better and how can we maintain this weight loss long term. And ultimately, I don't know if this is, oh, there we go. Okay. So, my overall vision is that my research would lead to the development of comprehensive weight management centers where people could get individualized, personalized care across the weight management spectrum, and could also be integrated with research clinics as well. If I were to put it kind of like in a visual, I would want obesity medicine to be treated more like dental medicine. So I have the tooth up here. I don't actually do any dental research. I go sometimes, I have a cavity. It's not even just a regular routine cleaning. I don't think that my dentist has failed me, and I don't think that I've necessarily failed at oral health. But we tend to view obesity and weight management as I wasn't successful, I failed, or if I regain the weight, I failed, or my provider has failed me, or any number of things. Record delivered weight management intervention, that those who reported greater engagement with professional support, whether it be physician, dietitian, personal trainer, they were less likely to regain weight over that 2-year period than people who did not engage with professional support. And maybe that's not all that novel, right? That maybe makes sense. But this ultimate vision, we really need to understand and have better weight loss trials and better weight loss options and better weight loss management maintenance options. I'm sure some of you guys maybe have seen this, but it's essentially findings from a potentially outdated now meta-analysis looking at different weight loss interventions in the lines and weight loss in kilograms here on the y-axis. And you see small, pretty transient. The next line below it, diet, blue, again, transient, and then green, diet and exercise together. And the reality is that most people want more weight loss than this anyway. And the other lines are some pharmacotherapy or specific, like very low calorie diets. And so this has sort of led to the idea that exercise is useless for weight loss. And I think that's where really public perception seems to be. That, if you exercise, it's just going to drive up your appetite, you're going to overeat, you're going to gain weight, or at best, you're going to not lose weight, even though that may be why you started. In one way, this is true. So what I'm showing here, and this has been shown multiple times, is a weight change here on the y-axis in weeks of an intervention on the x-axis. That solid black line is predicted weight loss based upon the energy expenditure of an exercise bout. Whereas these black squares are actual participant weight loss, so average weight loss of the cohort. And you can see there is a difference between that predicted weight loss and the actual weight loss. Individual responses, the story becomes a little bit more complicated. And so shown here is data from a project that I did during my postdoc, which we also recently published in TJ-ACSM. Sarah Purcell was the first author on this, and she's now at University of British Columbia. And so we have two different groups. This is a 12-week diet intervention or aerobic exercise intervention. And is shown in like a little circle or a triangle respectively. So when we look at weight change, the diet group predominantly lost weight. There were some people who didn't move that much. But when we look at those little triangles, each of them being a participant, it's a large range. Some people gained weight, some lost more weight than we might have predicted based upon that energy expenditure bout. And I did also want to just put up fat mass and fat-free mass just to answer the question of were they putting on a lot of muscle? And no, they weren't. This was an aerobic exercise intervention. So much of that weight that was gained or lost was fat mass in the exercise group. And so we've really thought about, some people are really successful, some people are not. And so maybe we need to look at this responder classification. And so we've classified people as responders if they lost at least 3% fat mass, or non-responders if they had less than a 3% fat mass change. Behavior and neuronal perspective to sort of answer these questions. So that's kind of the circle there with all the different ways we're addressing this. And so first, maybe people who are losing more weight with an exercise intervention are participating in more non-exercise physical activity, or the people who aren't losing weight, they're coming in, they're doing that exercise bout, but their other forms of locomotion, so becoming more sedentary. And so we hooked up active pals on these people. So here's me when I first got to Utah, making sure that all of my active pals worked. And I thought they were safe because they were in Tegaderm, they were wrapped. I gave one of them water damage because I took it on like a 12-mile trail run and so did too much. And fortunately, Pal Technologies gave me a new one. But so those of you who haven't used an active pal, it's like this little thing, kind of like about the size of 2 quarters. And you adhere it to your thigh, kind of halfway between your hip and your knee. And it gives you information on body location and also acceleration. And so from this, we can extract information on sedentary time, light intensity physical activity, moderate intensity physical activity, etc. And so we looked at our responders versus our non-responders, and there was really no difference between the groups. The only slight difference that we saw was that within the non-responder group, they were standing a little bit, but not enough to really mean why, to explain this weight difference between the groups. So then we also look at appetite and food intake. And so we do this with an acute meal challenge. And so people come in, they do in the fasted state at both baseline and post-intervention, they get in the fMRI scanner and we show them pictures of highly palatable foods or pretty like boring foods like celery, and also control pictures like a train. They also answer some food-related questionnaires, look at dietary restraint, disinhibition. And then we do a fasted blood draw and fasted appetite ratings. We give them a test meal, so about 25% of their estimated energy needs in a breakfast meal. And then we repeat those blood draws and those appetite ratings every 30 minutes. The only thing, we put them back in the scanner at the 60-minute time point. And so we didn't do the appetite ratings again, but we did actually go in there and were able to get a blood draw at that point. Then at the end of that 3-hour blood draw, we give an ad libitum meal. We present about 1,800 calories to them. They're allowed to eat as much or as little as they like. And so looking at some of the data, I'm going to first show you some of the hormone data. So the responders are in the gray bar and the non-responders are in the white bar. And again, each circle is an individual participant. And so we see no difference at all between groups or over time in ghrelin, which is a hunger hormone that's produced in the stomach, to this 12 weeks of resistant or of aerobic exercise. We also see no differences in GLP-1 between the conditions. Responders had higher PYY at both baseline and follow-up than the non-responder group. And so then we look at appetite, and so this is actually the area under the curve response, and you can tell those lines are pretty much on top of each other. I mean, I also set the scale to 0, which is impossible, but it's really the 180-minute time point that's driving that change in the area under the curve. That we classified as obese prone versus obese resistant. We did a overfeeding challenge and a eucaloric feeding challenge. And so for 3 days, these people either ate their normal calorie needs or they ate 30% extra. And then we brought them into the lab and they did a 24-hour stay with us. And Dan Bessison was the lead PI on this project. And a lot of papers have been published on this actually in obesity. So it's a really fun study to look up. And what we see was that in the people who are classified as obese resistant, they had a statistically significant increase in PYY, and this is over 24 hours, compared to, or not compared to the obese prone, but the increase in PYY in response to overeating was not significant in that obese prone group. Over time. And then we look at appetite. So we give a visual analog scale at baseline and at each of those 30-minute time points for 3 hours. And we ask people essentially rate how hungry you are from not at all to extremely hungry. And then we can calculate our area under the curve. And what we saw was that hunger area under the curve was consistently higher in the non-responders, both at baseline and post-intervention. And similarly, satiety was higher in the responders, but both at baseline and follow-up. So potentially there's something at baseline where if people present potentially with higher PYY levels, lower levels of hunger, they're going to be the people who are most likely to respond to your intervention. And then we look at 3-factor eating inventory. So first, dietary restraint. So kind of that ability to resist overeating in different situations. And the non-responders were unchanged in dietary restraint, but the responders had an increase from baseline to follow-up in that dietary restraint. And on this one, a lower score would actually favor less overeating. So a higher score means you're highly inhibited. You're going to be more likely to overeat when presented with some type of stress or challenge. And so the non-responders here, again, both at baseline and follow-up had higher levels of disinhibition. And lastly, we ask about hedonic hunger, and kind of in line with the other appetite data, those non-responders report And turning back to that obese prone versus obese resistant paper that we did. So we had that acute meal challenge where it was 3 days of overfeeding or 3 days of eucaloric feeding, and then a 24-hour study visit. We actually followed those people for 5 years to see what happened to them. And if we look at rate of weight change over that 5-year period, those with lower dietary disinhibition were less likely to gain weight, whereas those with higher dietary disinhibition, which was mostly driven by the obese prone group, were more likely to increase their weight over 5 years of follow-up, which this is really one of the fewer studies that would have that type of inpatient control. And then you also have 5 years of weight afterwards. So kind of back to the exercise and appetite regulation piece, we also look at, okay, well, what are they actually eating? And we did this in 2 ways. So the first is that to that 1,800 calorie meal challenge in the non-responders. And when we look at 3 days of ad libitum intake, so our metabolic kitchen packs up about 140% of their estimated daily energy needs, and we give that to them for 3 days, and they return anything that they didn't eat. And so we can see a little bit more free living, what their likelihood of overeating is. We've looked at this both as total calories, but also percent of energy needs, and it works out the same way. And then we've also looked at differences in neuronal responses to those visual food cues. And so we don't actually have any of this data just yet, but Christina Leggett, who's in the Division of Psychiatry, she's working on this data for this study. But I'll show you some data from a prior study that Mark Cornet, who was my postdoc mentor, did. And so first, what is fMRI? So functional MRI, you put a subject into a 3T magnet and you're exposing their brain to a uniform magnetic field. And then you have them do some type of cognitive task in a block design. So for us, interested in visual food cue or neuronal responses to food cues, some people actually feed people in the scanner. Some people will do a smell, and we just used pictures. So it would be a picture of, say, like palatable cookies flashed up pretty quickly, gone away, picture of bone broth soup, not that great, lower calorie, and then picture of like a chair. So, as your control conditions. And what happens is that brain regions that are active are going to have higher blood flow. And so those changes in neuronal activity lead to localized changes in blood flow. Sorry, that's covering it, but that's what it says. And then these changes in oxygenated to deoxygenated hemoglobin cause a detectable change in the magnetic field. And then you get these nice pictures where you essentially overlay one condition over the other and perform a t-test. And so here we're comparing the baseline to the post-exercise condition. And these all had reduced attention in the post-exercise state. And these regions are known to be involved in attentional bias, in motivation. And so what we're seeing is that post-exercise, people are giving less attention or less fixation to those hedonic foods. And this response was primarily driven by those who lost weight. So we saw regions and weight loss. So we sort of think that we'll see similar outcomes to that in this other study once we get through that data. To summarize, individuals with lower dietary disinhibition, hedonic hunger, and potentially higher PYY may be more likely to lose weight with exercise interventions and potentially to keep it off long term. And now during my PhD, I became a little bit of a meathead and I did some bodybuilding. And so my question is always, what about resistance exercise? No one gives it anywhere near enough attention. A study in a very similar population to our training study, where we did an acute bout post-meal of either aerobic exercise full body resistance exercise intervention, or they did a sedentary bout. And so each participant did all three conditions. And we did blood draws at the same time point, same ad libitum meal. And this form she wanted to highlight this in her Thanksgiving episode, and I was just so excited. And so I still have this up on my office door. And everyone's like, "Are you going to take that down?" I said, "Never. I'm keeping this up here forever. I've made it." And so looking at some of the appetite hormones, and I will say we had no differences between conditions in appetite ratings or in that ad libitum meal challenge post being a hunger hormone. It was actually reduced more post-resistance exercise than post-sedentary condition or aerobic exercise. And then when we look at our satiety hormones, we see that there was an increase post-exercise in the aerobic group compared to that resistance group. And that was also played out in the GLP-1 data as well. And a few trials, very few have directly compared aware of, and both of them were done in pretty fit, young, healthy males. And they saw this exact same pattern with reduced ghrelin response to resistance exercise and a peak in that PYY and GLP-1 following aerobic exercise. And in terms of, what's the mechanism here, we really don't know, but I believe it's most likely of that exercise bout because we were matched on time. So everyone was doing about 45 minutes of resistance training or 45 minutes of the aerobic. And clearly you're going to spend more energy on that aerobic exercise bout than the resistance bout. And there have been some studies looking at different intensities of aerobic exercise, and they see that these hormone responses do tend to respond to the intensity or caloric expenditure of the exercise bout. We have more to come in this area. We did do a longitudinal trial of just 12 weeks of resistance exercise on those same outcomes of the hormones, the behavior, and the neuronal indices. Or an abstract in for ACSM. And we saw that from baseline to post-intervention, we saw an increase in that PYY response to the test meal and a non-statistically significant increase in GLP-1. But no changes in subjective hunger, body mass, or body composition. So to shift gears just a little bit, this disinhibition piece kind of keeps showing. I love the hormones. They're like way cooler to talk about, but this keeps coming up. So maybe this is important and we need to kind of focus on this. So how do we address that part? And one idea I had, and this kind of came up as I was working as a dietitian, was postdoc. I'm also a registered dietitian, and so I was earning some extra cash because you don't make a lot as postdoc. And we have a 6-month weight loss program that's medically supervised meal replacements. And there was 2 sessions that focused on like mindfulness and stress reduction, and the participants loved it. Around that same time, the Anschutz Health and Wellness Center actually hired a clinical. It was great because we were able to kind of refer our folks to her. And so this got me thinking, like, maybe this is a way to actually address this weight loss maintenance space. And I love this picture personally because I'm an equestrian as well. And it's nice to think that like all my horse is thinking about is like the pretty scenery. But this is her, me and her out in Park City. She's a rescue, her name's Lily. But even though she's taking in the scene, mindful, she's very food motivated, actually. All of my animals are, so I'm not quite sure what I've done to them. But if we look at the data on the mindfulness interventions, it's been trialed in a variety of conditions. And the general consensus seems to be that when you offer this as a complement and not a solo therapy, it can be very effective in helping with anxiety, with fatigue, with depression, with PTSD, and potentially maybe a little bit with heart disease as well. And so I'm thinking, well, what about diabetes? What about obesity? And when you look at the literature on anxiety and depression in these groups, it's much higher in people without these conditions. And these conditions also have a pretty high social burden. And there's a lot of interference with, maybe relationships, with social interactions. And then combined with it, a lot of these conditions have a lot of associated complications, which starts this vicious cycle of increased anxiety, increased complications, increased anxiety. But when we look at scientific statements, and I'll just show one, but it's very similar. On cardiovascular risk or diabetes. But in general, the studies that have been done to date are pretty poor in quality. The methodological rigor is not really there, but they do seem to be improving over time. And so the mainstay for primary and secondary prevention of both cardiovascular disease as well as diabetes is still, your AHA or ADA guidelines. You could add it as an adjunct treatment because it's low cost and it's low risk. And then importantly, a lot of the trials that have been done so far in teams with a lot of bias, like they're the developers of course. And so I thought, I don't meditate, I don't do yoga, like I am perfect, I have no bias at all. So I can do this study. So overall, the evidence on mindfulness seems to be that, it might have some beneficial effects, including stress reduction and quality of life, but it's not intended to, nor does it prevent or cure disease. But what about weight regain? So it's not going to help you lose weight, but what about, will it help you prevent regaining that weight after you lose it? And so if we think about the trans-theoretical model or the stages of change, what we really need to do is to design weight loss maintenance interventions that prevent relapse and that are used in that maintenance phase. And where mindfulness has been shown to be conditions. And if we believe that obesity is a chronic disease with high relapse susceptibility in terms of weight regain, maybe we can employ mindfulness in that space and prevent relapse. So I did an initial feasibility study that was just an 8-week and I did have some historical controls that I was able to compare them to. We used a mindfulness program called Koru, which is designed more for younger people, but it was just what my collaborator was trained in, so we went with it. We recruited people who had lost at least 7% of their body mass within the last 2 months. Those that were in the Koru group, this is a group-based intervention, and they had weekly sessions for 8 weeks that were about 75 minutes to 90 minutes long. And it included doing breath work, chair yoga, meditation, and then homework on all of those things they learned in class. Now the control group, this was from a 12-week intervention that used the DPP's post-core curriculum, which is used kind of for maintenance. And so we went through that one-on-one, and they were given a caloric goal based upon their physical activity and their resting metabolic rate that we measured. So on all 3 of the groups, we have body mass data, or both of the groups we have body mass data, 3-factor eating inventory data, and weight efficacy lifestyle questionnaire as well. And then in the core group, because this was a feasibility study, we looked at satisfaction with the intervention. And we learned a lot of hard lessons. One was that recruitment and enrollment for this was super hard. I thought it was going to be easy because I was already coaching these people in weight loss intervention. I thought they would just join me. But as soon as I said, oh, we're going to focus on maintaining your weight, but okay. And so I say like, all right, well, when's a good time for me to follow up with you when you think you might be closer to your weight loss goals? I'd contact them and they wouldn't have lost more weight, or they would have regained weight and then they're no longer eligible to enroll. And this, is probably very institutional dependent, but we have a lot of other commercial weight loss programs at Anschutz, and they really do one and like take some paying guests. So that was a challenge. And then scheduling, we were doing this in person at the time, about 5:30. And that didn't work super well at Anschutz because most of the people who are going to do this study work on campus, and there's a lot of shift work. So you've got nurses that are, working 7 a.m. to 3 p.m. They don't want to wait for 2.5 hours. And then if you have people who are off campus and who don't live in Aurora, they don't really want to come out to Anschutz either. So that was a challenge. But in looking at some of our basic results here, the core group, 100% female, a little bit younger. Their average weight loss before entering the study was about 9%. And then our control group, we did have a couple of men in. There was an older group and their weight loss was closer to 14%, but they had just come, most of them, off of a meal replacement-based weight loss program. Looking at weight change post-intervention, it was so we don't really expect much weight regain to happen over an 8-week period. But if we look at some of our eating related behaviors of dietary restraint, disinhibition, and hunger, so in red is the mindfulness group and in black is that DPP control group. And we see that restraint is increased in both groups and hunger is reduced. So maybe there's something to this mindfulness piece that's resulting in some of these changes. We also looked at weight efficacy. And what this is there's 5 domains and the score ranges from 0 to 36. And it's how confident you are, how much self-efficacy do you have that you could resist overeating in response to some type of challenging situation. So whether it be negative emotions, availability of food, social pressure, physical discomfort, and even positive activities like your activities kind of all rolled into one. And we see that, maybe there's some movement, in both groups on these outcomes. When we look at our participant feedback, we asked about their satisfaction with the content of the program, meeting structure, and their weight loss maintenance. And the average of the scale out of a 1 to 10 scale was a 9. So people really liked it. And then we did some qualitative work. We learning how to do mindfulness. Some people said that they were able to take some of these activities like into their daily life. And so when they were, for instance, like doing the dishes, they're able to be like more mindful and like feeling the sensation, or even when they're exercising, they're feeling like this is what my muscles are doing. The only 2 negative comments that we had was one person everyone. So to kind of summarize this, recruitment and enrollment are pretty challenging. Short-term mindfulness appeals to be effective for weight loss maintenance. And participants really enjoy the intervention and find value in it. But for future interventions, we really need to reframe it from a weight loss maintenance intervention to a weight regain prevention intervention, and tell participants that if you still are wanting to lose weight, you can, but we're just not focused on that in our exercise intervention. For my current KL2, this is exactly the approach that we took. We said, we just want to prevent you from regaining that weight, but whatever you want to do on your own time, you can do. Also, we thought we probably need to shift this to more of a virtual delivery or one-on-one. The challenge with going to one-on-one, I don't know if any of you have done individual versus group-based weight loss before, but better in a group-based setting than one-on-one. It can be harder to recruit into those group-based interventions, but it's also easier on your staff in terms of the resources that you put forward. So we're still doing this intervention in a group-based setting, but we did move it to Zoom. We also switched up. We're not doing Koru. We're using a program called MORE at the moment, which stands for Mindfulness-Oriented Recovery Enhancement. One of my K mentors, he developed this program. He's a clinical psychologist, he's a clinical social worker. He developed this program in the context of drug and alcohol misuse disorders and has shown prevention of opioid misuse with just this 8-week intervention over a year of follow-up. And then lastly, we definitely need to target much more diverse audiences with these interventions. So kind of some final thoughts. I believe lifestyle interventions can result in weight loss, but the response is heterogeneous and it's also generally small. There's a recent paper that was published looking at different pharmaceutical weight loss, and I just added in the exercise. And so this is placebo subtracted weight loss, and you can see that you're getting a very small weight loss, maybe like 3% with exercise. As drugs, you're getting substantial weight loss. And I didn't put bariatric surgery on this, but it would be off of this chart, which I'm capping at 18% weight loss. And so I think we need to focus on longer term maintenance interventions and utilize new approaches like potentially mindfulness or some other more novel things, because getting people to keep doing the same thing out of it. And then I think, kind of based upon that other slide, we need to combine forces with pharmacotherapy and lifestyle interventions to really achieve and maintain weight loss long term. What we're hearing, one of my other K mentors, she's a physician, and she's putting on some of these new anti-obesity meds. They don't want to be on them long term. But from the STEP 4 trial, which Novo Nordisk funded, they'd had initial weight loss phase, everyone got semaglutide. Then half the group came off and went on placebo, half the group stayed on semaglutide, and those that came off regained the weight. And so that's what physicians are having to tell their patients. And they are concerned about long-term what are potential outcomes that we're not aware of right now. And so maybe there's a place for some of our more lifestyle interventions to enter after people have achieved a significant amount of weight loss. And so with that, some acknowledgements. A lot of the work that I showed was done at the University of Colorado when I was a postdoc with Dr. Mark Cornier, Dr. Ed Melanson, as well as a whole host of other folks. A Mighty Lab. So Celine Tobin, she's a second-year PhD student with me right now. And she's fantastic if anyone's like looking for postdocs or junior faculty in the future. Like, she's going to be a star. Grace Zimmerman, also a second-year PhD student with me, also doing great work. And then Jason Thomas, he did his master's with me and has stayed for his PhD. And I didn't talk about any of this work today, but we're getting into timing of resistance exercise and glucose control, which I talked a lot about in my individual meetings. And so he's going to kind of spearhead some of that. And then Tori, she's my great study coordinator. And then we have CTS staff that help us out. So with that, I'd love to take any questions, have a discussion. And if anyone wants to come and ski with me in Utah, this was actually taken on the backcountry on the other side of Alta. So down in the canyon of Salt Lake, and really quick, we can be up in these beautiful mountains.
What kinds of results are you expecting to see? In relation to that, you did the fMRI, I think, at the initial stage when they had not been given any meal, then 1 hour was 1 hour. Do you think there could be some learning? They are very close together in terms of what do you anticipate in terms of learning?
Yeah, that's a good point. So we haven't analyzed the data from the exercise versus diet intervention or any of that fMRI data, but one of Mark's prior studies was just an exercise intervention. And it showed a little bit of that responder, non-responder effect, in that those that lost weight had greater reduction in some of the insulin response primarily to those visual food cues. In that prior study, they did not do a fed versus fasted comparison, I don't believe. And so we thought that might be important to do in this case. But there had been previous literature showing that in adults with obesity compared to lean adults, in the fed state, everyone is like kind of hyperfixated on those calorically dense foods. But in the fed state, adults that are lean have kind of turned that off, whereas even obesity or overweight still have that same drive. And so everyone in the study had to have overweight or obesity to be enrolled. But I think what we might see is that those that are responders to weight loss probably are going to have that reduction in the fed state, whereas those that are not probably will continue to have that same response, whether they're in the postprandial or preprandial state. But yeah, I'd be interested in your thoughts. I know you're doing some work in that area.
In the learning bit, do you think there could be some learning in this, considering how?
Yeah. Oh, yeah. That's a good point. Because they just saw these images. So we divided them up so they didn't see the exact same ones each time. But yeah, that's a good point too. It's like they haven't just done this. We do have them do like ratings as well, but we don't have them do the ratings in the fMRI.
Also, you read the pictures separately outside of this. Wow.
Yeah. Yeah. And I tried to do that during my that honest. and it just like busted. And I was like, we don't need to worry about this anymore. So, but it was funny because we did have, one person was doing that in the acute study, and I don't know, I guess like, it was like they would show 2 pictures at a time and they had to pick which one they liked the most. And then I brought them out their test meal and they go, oh, I didn't pick lasagna. What are you talking about? Oh, this wasn't based upon what I just did. No. So that was kind of funny, which, brings up questions about, what are these ad lib meal challenges that we're doing? Because it's not the same for everyone. And it's easier if you can keep it consistent. But I definitely know labs where they will like tailor those meals to what people rated as the most palatable. So there's a lot of, I would think there's a lot of methodological work that needs to be done in that space, but no one's going to fund it. Yeah, either one.
Thanks for the talk. I hate to change slides.
Oh,
but
happy.
I'm going back to that slide you had like predicted.
Oh yeah, all the way. Yeah, so this specific study, that bar right there was actually, I think, an exercise, 8 weeks of exercise, and they followed them up. I think they still have the diet group going. So yeah, I don't think they accounted for that. So 24 weeks, right? So we're looking at 6 months. I would imagine so, because I'm assuming they was just basing this upon 3,500 calories is equivalent to a pound of fat, which in the first few weeks, like that tracks super duper well. And you're right, it does, like that is part of what happens is, so I think we do need to be better about accounting for that. And NIH has a really good body weight planner that Kevin Hall's developed. And so I think like a better prediction of that predicted weight loss versus actual. Yeah, that's a great one.
Just curious, what criteria you use to put participants into this program?
Yeah, so for starters, we basically just asked them. That's one of the criteria, really was like, are you someone who feels like you can kind of eat whatever you want without gaining weight? You don't have to watch your weight. Or are you someone who has to be super regimented or you will gain weight? That was one of the criteria. And then the obese prone group also had to have a family history of obesity, and the obese resistant group had to have no family history of obesity, but that was essentially it. Because like we kind of all know people who like say that, so just let's go, what do you think? And then with that family history, so there's some potential genetic component making them obese prone or obese resistant, or, gene environment interaction there. Yeah.
Can you go to the PYY change
Yeah.
slide? So you were talking about how it looked to me like the people who started low and went high, not the people who started high. That the beneficial effect is change start from a very low. There it is.
Oh, this one. Yeah. Yeah.
We're fed, they're lower in the youth.
Right.
Can you just talk a little bit about that means or what?
Yeah. So you're talking about like the obese prone bar is higher than the obese resistant bar, or
If at the overhead are very much the same.
Yeah.
What's different is in the eucaloric state, the PYY is very low.
Yep.
in the obese
Yep.
group.
Yeah, exactly. And so I think, we don't know for sure, but I think that change is super crucial because we went from, you're eating your caloric needs. So, maybe your PRI levels are like some level of baseline. So now you're overfed. So like that change, like that drastic change is a physiological response that you're going to be your brain's going to be responsive to. But yeah, that's a great point, is that they are lower at that fed state, which is
Could
interesting.
obesity prone be resistant?
Yeah.
PYY in the eucaloric.
way on like, oh, leptin resistance.
Yes,
And so we're like, oh, they're just like, you know, you have this set level that's pretty high. And so you're not going to be as responsive when it goes higher because you already have this like sort of threshold that you're not responding to. Yeah. Yeah.
And really great talk, but does so Paul McLean does a bunch of obesity prone and
Yep.
resistant rats.
Yep.
Does he show the same thing in those rat models where they know in fact that they are prone or resistant? Whereas you've got a little bit of subjectivity and okay, ask my mom if she gains weight or not when she looks at food. And there's a little bit of less objective.
Yeah. Yeah.
Do you know if he's showing the same thing?
That's a good point. I know most of his is like on preventing weight regain after weight loss, like with or without exercise. I'm not as familiar with like the obese prone rodent model versus not data. So
so the question would be, are the obese prone animals having higher PYY?
yeah.
Yeah, does this mirror a model where we know in fact that they are quite resistant? And quite
Yeah,
resistant?
that's a good point. I don't think they've done any like direct like PYY kind of resistance stuff. It's been more like the leptin resistance kind of framework in the rodent models. But that's it's a great point.
Then I'm really not shocked, but if you look at your activity and your participants, if you go a couple of slides ahead of time, was this collected in Colorado? Was this collected?
This was in Colorado.
Yeah. So you've got steps per day at 4,000. Like, that's Missouri.
Yeah. Yeah. So we just had someone come to speak at our seminar who was Jonathan Mitchell's at University of Pennsylvania, and he does adolescent childhood, or no, sorry, it wasn't. It was David Conroy at Penn State. And he was recruiting a group of college students who he was calling like insufficiently active. And they had to finding college students that get less than 3,000 steps per day. He's like, oh, they're out there. And then I was looking exactly at this and I was like, oh, I told him he was full of crap. Yeah. Yeah. And then I was like, oh, I guess we do find them. So we had screened them with the IPAC. So they had to be below the physical activity guidelines according to the IPAC. And the IPAC tends to overestimate physical activity quite a bit. So yeah, I mean, these were just like people who had jobs and children and drove to work and drove their kids to sport. And that was kind of their day, to be honest. Yeah. Yeah. And we took, and perhaps obviously, maybe I should have said this, like we took their exercise bouts out of the follow-up. So this was just their non-exercise, physical activity.
So shifting gears, to talk about the mindfulness work, how do you think that compares, or is it really just gearing people up to eat intuitively?
Full eating intervention where I'm sure maybe you guys have sat through that where it's like you're going to take 10 minutes to eat this almond and you're like, I'm good, I don't really want to do that anymore. Or like the chocolate where it's like it sounded good at first and you're like, this is disgusting. So we were really focused on more of just like building like an overall general mindfulness muscle. Sorry, I just totally lost track. What was your question?
I discovered about the mindfulness.
Oh, and mindfulness, I think, are super similar. But for the most part, none of our mindfulness sessions focus at all on like weight or eating. We do one exercise that's like the mindful eating exercise, and that is it. That's the only one. And we actually do it in Eric's initial MORE program. They do that exercise a lot earlier, and he has them visualize that like that candy or whatever it is like their drug of choice. And in the exercise, it's their choice if they want to eat it or not. So when it's in person, there's like a trash can in the middle of the room. Like you make the choice. And so then on Zoom, it's the same thing as like you make the choice whether you consume it or not. And we moved to that later in the program for the weight loss maintenance intervention because we thought, it's not a drug, but like this is like their equivalent actually in front of them. So we moved a little bit later after they'd already had a lot of mindful meditation practice. So maybe we do also, so in Eric's initial program, they have to do 3 minutes of mindfulness just at some point during the day. And we actually asked them to do 3 minutes of mindfulness prior to meals to maybe cue for that. And also just ask them to be more in touch with their body, like what is your hunger and satiety and stuff like that. And it wasn't even saying what is your hunger and satiety, but just doing that 3 minutes of mindfulness might set them up to then make a more maybe perhaps intuitive choice. Yeah, I think that's a good point. I'm not aware, there's probably are some like tightly validated intuitive
Just a quick question, about across your studies, did you look at sleeping patterns and the effect of sleep on eating behavior?
So in the training studies, we did not. In the acute study, I mean, we look at it basically just to remove it. So that way we're looking at physical activity or sedentary behavior normalized to waking time. One of my students was interested, and so he looked at, was there a difference in sleep between an acute bout of aerobic versus resistance versus sedentary, and there wasn't any difference. I now have, and he's a sleep and circadian physiologist, and so we're really like getting into some collaborations here. Most of his work's been in restricting sleep and looking at insulin sensitivity and eating behaviors, and shocking, people eat more and their insulin sensitivity is crap. And so we've got a time restricted based study that we're starting up soon that we got some funding for that started in January, where we'll also, and these people have habitual short sleep duration. We've got a sleep extension study that he's doing right now. And then we got some pilot money to look at how AM versus PM resistance exercise impacts glucose tolerance, but also sleep duration, sleep efficiency, and sleep staging. And so I'm really interested to see where that goes. One of my colleagues who's still at Colorado, Seth Creasy, he and Eric Willis, they did a secondary analysis of the NEP trial from Kansas. I don't know if you're familiar with that. 16-month weight loss study, aerobic exercise, college students. And they went back and they looked at the timing that those people worked out. And they saw that those who exercised predominantly in the morning or were more sporadic lost more weight than those that exercised in the evening. And then they went and did a pilot randomized controlled trial of it. And there was no difference in weight between the AM and PM group, but the morning group lost 10 minutes of sleep a day on average. And the PM group increased their sleep by about 30 minutes on average. And so we have some pilot data that we've looked at. Other sessions in the afternoon or evening group compared to the morning group had a lower glucose area under the curve response to an OGTT. And we don't know why that is. So we put in another grant to hopefully get some funding there. But one of our thoughts is that sleep changes in sleep may be driving that. So if you're sleeping more, you're going to be potentially more insulin sensitive. Yeah. Any other questions? And if there's anyone on the thing, I can't really see it. But okay, perfect.
All right, let's now.
Yeah, thank you so much.